Hello, my name is Schunkert. I'm director of the Cardiology department at the German Heart Center in Munich, and I'm speaking to you from the Congress of the European Atherosclerosis Society here in Maastricht. My topic is the genetics of coronary artery disease, and in this field we have made some remarkable discoveries over the last 10 years. Indeed, by now we have identified more than 160 chromosomal loci that carry genetic variants that affect the risk of coronary artery disease. And I can tell you by end of this year, so let's say in early 2020, this number will have increased to more than 200 variants that achieve the genome-wide significant levels. So what you can see on this slide is that if one looks at the genes at these loci, they fall into different categories depending on their presumed function. What we see is traditional risk factors like lipid metabolism and blood pressure, but indeed many of the functions of these genes are currently unknown, so there's lots to be understood in terms what the mechanisms are that promote atherosclerosis. If one has a look at this genome-wide significant risk factor loci score, then one finds, of course, genes that promote the relevance of traditional risk factors like hypertension, type 2 diabetes, and hypocholesterolemia. So they are participants in this score. But this score then, if one relates it to more complex diseases, is not only affecting coronary disease, but also other versions of atherosclerosis, let's say large artery stroke, peripheral arterial disease, abdominal aortic aneurysms, and aortic stenosis. All these conditions are significantly related to the level of this genetic risk score. And even beyond coronary artery disease, there are other conditions that are highly significantly associated, like heart failure as a consequence of myocardial infarction, atrial fibrillation, and even premature death. So if one looks at the genetic architecture, one can trace the signals in many other severe cardiovascular conditions. So if one looks at the population level, particularly the group in Boston from the Broad Institute, Sekar-Thrasin and Ahmed Kara, have told us that the higher the score is, the higher is the risk of coronary artery disease. So here you see the 20-year risk in a physically active and healthy individual, depending on the risk score. It's about twice as high if one resides in the upper quintile of this score as compared to the lower quintile. But if then one looks at the actual number of risk alleles, the difference is relatively small, only 12 risk alleles. So despite this little difference, there is a significant difference in cardiovascular risk. And if you go even beyond to the very extreme levels, let's say to the top, whatever, 3% or 2% of this particular score, then the risk jumps up enormously to develop coronary artery disease or some other severe condition, as you can see here. So the surprising thing is now, if one takes the current situation with the 164 risk alleles, one can realize that all of us have at least 120 or 130 risk alleles. And despite this large number, the risk actually in those people who are sitting at this level is relatively low. But then it jumps up exponentially. So most of us have something like 150 to 170 risk alleles. So here the risk is already 3 times higher than in those who have the extreme low numbers, and that goes even up further in those who have the highest number. So the surprising thing here is that there seems to be an exponential increase in risk depending on the number of risk alleles, but also that there is a threshold that seems to be harmless unless we don't increase the number. So now what we have to do is to find methods to bring everybody down to the risk of a person who by nature has only, let's say, 100 or 110 risk alleles, and then we have a chance to abolish coronary artery disease. So that will be my messages for the plenary lecture tomorrow.